place an intracranial stent. Typically in my practice, I use balloon-mounted coronary stents that can be either bare metal or drug-eluting. In this case, I elected to use a bare metal stent. And in that situation, I give the patient Integralin, which is a 2B3 inhibitor, intravenously, and then load the patient with aspirin and Plavix after the procedure. So for this setup, I had a ballast catheter in the left vertebral artery, and then I advanced a short Cat5 catheter for distal access. Through the Cat5 catheter, then I advanced a Synchro micro wire, an 014, into the left PCA. So you can see in this image, over this left vertebral artery angiographic run, I was able to then advance through the Cat5 a 2.5 millimeter by 14 millimeter balloon mounted stent, and the distal stenosis that was previously high grade is now patent. The proximal stenosis persisted, and therefore I elected to place a second stent. And so this is now the result after the placement of that second stent. So now I have good patency of the posterior cerebral artery, the upper basilar high-grade stenosis, as well as the lower basilar stenosis. So these three lesions were now addressed with aspiration, stent retriever, followed by placement of 2 tandem stents. At this point, I realized that I had an issue. The first stent that was placed had actually trapped the synchro wire due to looping of the wire that I had preferred to have a J-shaped wire to provide avoid perforation of the posterior cerebral artery during the manipulation and advancement of the stents. But in doing so, I had a lot of redundancy of the wire, and the first stent I had placed had now jailed the wire between the stent and the vessel itself. And so when I tried to remove the stent retriever, which I would normally just pull down, I was catching on the stent itself, and the wire was stuck. So in this sort of cartoon illustration, you can see that the wire forms a J shape, and then the tail of the wire is trapped behind my stent here. So as I try to reduce the system, I was able to get this much of the wire out, but the last portion of the wire remained caught behind the stent and the vessel wall. And so at this point, I was reluctant to apply more pressure in pulling the wire for concern of causing rupture of the blood vessel wall. In order to then retrieve the wire, I decided to, through the Cat5, advance an SL10 micro catheter up to the tail of the wire to provide more support. And with that configuration, having the micro wire at the tip of the wire itself, the SL10 micro wire microcatheter combination, I was able to then gently retract and pull out from underneath the stent. So this is the final angiographic result. You can see that where I was manipulating the stent and the basilar artery, there is a small indentation. So there was some manipulation of the vessel related to that maneuver. However, there was no extravasation or perforation of the vessel, and follow-up imaging revealed no hemorrhagic complication from the procedure. As I mentioned, I gave Integralin just prior to stent deployment, and then after the procedure, I loaded the patient with 325 milligrams of aspirin and 600 milligrams of Plavix. So this is my last slide, and I'll take any questions if there are any.
Thank you very much, Ashu. That was a really interesting case. There's definitely a lot of possibilities here for discussion. Definitely, we are going to focus on the complicate or on the challenge that you faced, but it's very interesting approach. I mean, you decided to really wait for 10 minutes without any antiplatelet medication to see if before you throw a stent. Question for you is, do you think that if you would have used some antiplatelet medication before making that decision of dropping the stent, you could have still keep the vessel open? Because this is endothelial, it's a plaque, there's probably endothelial damage that has caused the thrombosis. And without antiplatelet IV or PO, obviously PO will not act right away, but the IV medication, do you think you could avoid a stenting in this kind of cases?
Yeah, that's a good question, Santi. So I think that one approach to these situations is you give the integralin off the bat before you commit to a stent, and then that way you have platelets suppressed, and maybe that'll reduce the likelihood of the vessel reoccluding. But to some extent, you kind of want to see what's going to happen. You might be able to bridge this or temporize it with some 2B3 inhibitors, but I would be worried that you may buy yourself an extra 10 minutes and then the patient just reoccludes an hour later, 2 hours later in the ICU. So I think that you could do this both ways, because obviously you're going to give them antiplatelets if you're going to commit to stenting as well. And I think that partly what this case highlights is the challenge with basilar artery occlusions, that they're more likely to need some kind of rescue therapy. And especially if we are trying to take a stent retriever versus a medical therapy approach to the trials, for example, for basilar artery occlusions, then that may not show benefit, because if these patients need rescue therapy, then a stent retriever alone may not be the solution. So, especially if we look at these recent trials that were done in China, the BEST study and then the Bao-Che study that's ongoing, I do think that sort of confounds the interpretation of those type of studies, because this population tends to have more ICAD, more need for rescue therapy, and just a single modality, whether it's aspiration or stent retrievers, may not work as often. So this is obviously a typical situation, multifocal occlusions, but we've seen it was just isolated basilar artery stenosis.
I don't know if Max is available, but if not, I would like to ask maybe you or Mario if you think that I think in this case it was critical to have the support, right? I think the fact that you advanced the SL10 right to where you had the microwire trapped and having also an intermediate catheter so high up gave you the opportunity to really exert a little bit more traction without very, very close by, and also the tip of the SL10 probably kept the stent from displacing. But any other potential approach that you can think of to deal with this unfortunate situation when you have the microwire kind of trapped by the stent? Anything, Ashu or Mario, that you kind of think of besides what you just did?
No, so my concern, Santi, was the type of stent. I don't know if you guys have specific interest, in what specific stent, balloon assistance stent, or for example, for us, we're using a lot of the Atlas in the acute setting. We have also, I don't know if you have it there, the NeuroSpeed balloon, and you may deploy the stent through the credo through the balloon. So I think at the end, we are dealing with this new, technology that we have for intracranial stenosis. I don't know if you have it there in the US, but I think we need more tools, for this procedure more safely.
Yeah, no, I think Ashu's stents were coronary stents. The Integra you mentioned, right? You use balloon-mounted coronary stents. Max, anything that you have done differently in this situation from what Ashu did to kind of take the stent out from the microwire out from the stent?
No, we use the same setup. Santi and Ashu, that we share these cases, and it sounds like the setups we use are very identical throughout the country. But what I'm curious, what happened is the same thing happens with flow diverters and aneurysms. We focus on one region, we totally forget the rest of the screen. So I'm more curious in general, did this case in any way change how you approach angiography in general? Do you ask someone in the back to keep an eye on other regions? Because I've had the same issue happen with Onyx cases. It just, there is a big blind spot, right? We only see 10% of the screen. That's where the device is. The rest we ignore.
Yeah, I mean, I think we create a new problem by trying to solve another problem. So, this approach of having a jade wire, I learned the hard way, because when I've done this in the past without a jade wire, and you've got this wire floating around in the P2, you're paying attention to the stent deployment, and you don't realize your wire, catches a perforator, or and so I've had a case where, caused a perf in the PCA. Didn't even realize it at the time because you're focused on the basilar stent. And so my solution has been then to go with a jade wire. And what I've noticed personally is that there's two ways to do this. One is you go with the microwire catheter, and through the exchange length microwire, you remove the microcatheter, and that involves an exchange. So when I do it that way, I can preserve that J wire from being less elongated. The problem is an extra exchange step, removing the microcatheter. What I've done recently is just gone straight up with the microwire, but because it's a diseased vessel with plaque and all kinds of stuff happening in the vessel itself, the J tends to catch, the tail of that wire catches somewhere, and then my J elongates. And so again, to solve one problem, which is to not have to do that microcatheter exchange, I just go primarily with the wire J-shaped, but then the J elongates because I don't have the microcatheter there to reduce it. So you're absolutely right. I think the solution to this is to have an extra pair of eyes, whatever you're doing. And I think that definitely makes a difference. And that's usually what I have, the fellow or whomever is scrubbed in to say, okay, you keep an eye on this. And, I think of all the procedures we do, I still think intracranial stenting for atherosclerotic disease is one of the higher risk procedures. So I'm so focused on not overinflating the balloon when we deploy the stent and a million other things. And I tend to do my strokes awake. So this is an awake basilar artery occlusion patient. I don't want to hemodynamically compromise them by intubating them. So you got a lot of things happening at the same time. So, but I agree with you. I think that these kind of cases reveal the blind spots, and certainly, you try to make sure that you don't make that same mistake again. I have a question for Mario, because I can guarantee you half the time when you ask us, do you guys have device X? You can assume the answer is no, we don't have that device for another 5 years. But I'm curious now, with your solution to this type of problem, do you need a wire then, or do you have a balloon up there that you've already delivered, and through that balloon you deliver the stent? Can you explain that?
Exactly, it's like a double lumen balloon, exactly as for remodeling. So do you do the angioplasty, remove the wire, and through the balloon you may deploy the stent. So I think it's a great advance for this disease. I make the difference completely.
And what's the stent that you typically deploy through that?
It's called Credo. Credo is from Acandis also. It's very similar to Winspan. So the radial force is high. But yes, I think it's the big step for the treatment of intracranial stenosis. I'm pretty sure that more, the companies working on it. So we need that kind of tools.
What Mario mentioned is very interesting. The fact that some people might choose an Atlas stent since we don't have the technology that they have available in Europe. Would you consider in situations like this, or maybe if the case was instead of the basilar artery, let's say we are dealing with an M1 or distal ICA, that would change your mind and choose an Atlas and do angioplasty, or you still choose a coronary stent?
You're asking?
Yeah, for you.
Sure.
This is for you.
So I'm still, I've had an unfortunate experience with Atlas and similar intracranial nerve stents. So for me, it's a balloon-mounted coronary stent these days, 100%. I just had plaques, and they would just squeeze the stent back. Now, this trick with angioplasty through the gateway balloon and then deploying. I haven't tried it, but I've heard it more and more. So perhaps I'll switch, but coronary balloon mounted
If I
stents
may
is my
add
way to go.
something, Max, and I think in my opinion depends also for the angioplasty. So if you do an angioplasty first and you may recover, at least 30% of the lumen, then it's very safe to place an atlas, But if you are not able to do a gently angioplasty, just, with no inflation, there has no sense to put an atlas. So I think it depends of the previous angioplasty.
Yep. Absolutely agree.
Very good. I think, Mario, we can probably go to the next case since we have already a very nice discussion. Really great case, Ashu. I think it's something that definitely we're going to face at least 15 to 20% of the cases with the ICATs that we deal with for mechanical thrombectomy. And now for the second case, I want to also introduce a close friend and a really amazing endovascular interventional neurologist, Diogo Hausen from University of Emory. And he's going to talk to us about another interesting ischemic case that he faced recently.
Hello, thank you very much for the invitation. It is a pleasure to be here with you. My name is Diogo Hausen. I'm from Atlanta, Georgia, US, Grady Memorial Hospital and Emory University. We'll be talking about an unusual scenario, which I hope that is going to add educational value to this summit. These are my disclosures. So an octogenarian patient with hypertension and contralateral carotid endarterectomy, previous endarterectomy, presented to an outside hospital, to a partnering hospital with a left medial cerebral artery syndrome, which was more than 30 in terms of NIH Stroll scale. This patient was then intubated for airway protection in there, started on IV TPA, which was then stopped due to epistaxis and transferred to us. Upon arrival, and you can see here, there's a hyperdensity in the medial cerebral artery, and there's some loss of the gray white differentiation in the operculum, frontal operculum insula, and the rest of the parenchyma appear to be looking very good. The CT perfusion, the automated CT perfusion software demonstrated no clear core and a large area of perfusion defect as expected. This is the CT angiogram demonstrating and confirming the occlusion that we had discussed. And this is the CT angiogram demonstrated some calcifications in the siphon, in the arch. A lot of artifacts. We lose the ICA, and then it reconstitutes higher up at the supraclinoidal segment, as you will see here, with the occlusion at its distal segment as discussed. Our setup has been historically a 9 French short sheath with a concentric balloon guide catheter at 9 French. This patient was particularly very tall, and the decision was then to use the longer version, which is a 95 version, and the Orion 21 microcatheter from Medtronic, which is not currently available anymore, which is a 150 centimeter microcatheter, and also a Synchro 2 microwire. And I don't have any conflicts with Medtronic, so I just wanted to show you that this was an interesting design for a microcatheter with a hypotube and also a nitinol braid that would allow for great pushability and trackability. The delivery of the stent retriever was perceived to be very smooth and also had a very slim profile, which is something that I personally think is relevant when crossing the clot. This is someone that you may know, basically demonstrating the differences between a Track 21 and an Orion, which looks like a fishing pole, has a very sturdy structure that, again, we had connection to. This is then the VTK doing an injection in the common carotid artery, and you see that there's a stump. And you also see that there is some degree of reconstitution of the internal carotid artery through external branches. In those situations, we try to put the balloon guide catheter all the way into the stump and then inflate and maintain it inflated because the carotid was occluded regardless, then do a pass and pull the clot from the intracranial circulation, also clean up in the bulk the carotid bulb as you're coming down while the balloon guide catheter is inflated with vigorous aspiration. However, the balloon guide catheter kept coming down, and they didn't want to kill those ECA collaterals that could potentially be helpful for the next few minutes while I was doing the reperfusion. So the decision was to then inflate, cross with the microcatheter, and then deflate to maintain patency of the external carotid artery. The issue here is that this patient was tall and the balloon was low, and this microcatheter was 150 centimeters, and gladly now there are 160 centimeter microcatheters that are very helpful, but I just couldn't cross the clot. This is just an illustrative a view of the clot, the micro wire across. I basically couldn't advance it further. I didn't have enough microcatheter, that was my perception, so I tried to advance the wire to have the stiffer part of the synchro, give him the support to track the microcatheter. It didn't really work. I tried to pull the forward of the microcatheter and try to advance again multiple times, which was not really effective. So the decision then was to inflate the balloon guide catheter for additional support, which we call balloon guide catheter anchoring. So once I did that, I had much more support, and this allowed me to push the catheter with more force. And as I'm pushing the microcatheter, I realized that something unusual and very problematic had occurred, which is what you can see in here. This is the proximal marker, this is the distal marker, and there's clearly redundancy in the catheter. The lateral view demonstrated much more clearly. There is this very large loop inside, which obviously is not compatible with the diameter of an intracranial vessel. So I immediately understood what had happened, although didn't really fully understand how it had happened. But the impression here is that there was infolding of not the very end, but the distal end of the microcatheter on itself due to excessive pressure. And that led to this infolding that you can see here. Very likely the microcatheter comes this way, folds around, and then it comes this way. So we have some tip actually probably that moved forward, went across the clot, but it ended up happening like that. This is the frontal view as I'm reducing it. So this is a negative or blank mask, and you can see that I'm pulling down and then it's not even moving yet. And this is the lateral view, is a little more clear. Starts coming down, and then as I keep pulling back, it's starting to stretch this segment and undoing that loop. I'm just gonna play it again. So the golden rule of neurointervention, which is do not force, was not probably followed properly here. I did a microinjection through the microcatheter, and very likely due to the competitive flow with the external carotid artery that we talked about, and probably some degree from the ACOM, I just couldn't see anything. So the decision was to just slide a Navion through that occlusion. I did a very gentle microcatheter run, and you can see here, obviously, the extravasation as expected. I'll play again the lateral. Pretty much in the site where the loop was present. I took then a 21 microcatheter right into it, and then did what everyone would probably do, which is to coil it. We still had an occlusion at the level of the neck, which was helpful. I kept coiling, and as you can see, this branch is still preserved, although it was in the middle of the coil mass. And at the end, we unfortunately lost that branch, and at least the extravasation had stopped. This is just a fluoroscopic view of that same area with the Navion and the 17 microcatheter at the end. I decided to do a contralateral run, which you can see here that doesn't get properly compensated through the anterior communicating artery. So due to this bad ACA to MCA collateralization, I wanted to consider revascularizing the ICA now that I had probably tamponade the metacerebral artery tear. So I pulled the Navion under aspiration. We generally use the vac lock, a 60cc vac lock, and I got clot removal. So I debulked the lesion, and then I was able to do a better run. This, as you can see, is a common carotid artery run. And it demonstrates obviously the large area of oligemia, but preservation of this inferior, more temporal branch. This is the flat panel CT immediately after the procedure. I'll play it again. Obviously, a good amount of hyperdensity, predominantly contrast in the Sylvian fissure and probably contrast in blood and the rest of the brain. It was not as bad as I expected, and unfortunately, the MRI that was done around 24 hours demonstrated evolution of the stroke into a complete mid-cerebral artery stroke. This is the GRE. The blood content is not really that substantial, but once again, the DWI was very negative. So that's basically what I wanted to share with you, and I hope that we'll have a good discussion. Thank you.
Well, thank you so much, Diogo. What a nightmare. Definitely exemplifies what we're trying to kind of show here. And unfortunately, we have to face these cases, hopefully not very frequently. But there are a couple of things that I'm interested in, maybe I missed when you were mentioning. It's not clear to me exactly how, as you said, how the microcatheter was advanced and you had the loop. But do you think that when you saw that it was so distally advanced and you have that loop shape, you were already perforating and you were already in the superaccurate space with the microcatheter? I think you are on mute, yeah.
Yeah, I just unmuted myself. How's everyone? Thank you for the opportunity of sharing this case. Once again, this case is from multiple years ago. I unfortunately didn't have screen capture or the screen capture software, so I just have some fragments of the procedure, but I just thought it was unusual and I just wanted to share that with you. I still don't fully understand. I remember, I think as I mentioned in the presentation, that I really wished 160 centimeter microcatheters would exist, the 21s. I don't think at the time they did, because I think I just needed a little more. I was relatively stretched with the microcatheter. So I ended up having to force to see if I could get through. I didn't see any better solution besides trying to revascularize the ICA first, which is not what I used to do and I still tend not to do. But I was forcing, and then suddenly that happened. It was honestly so fast that I didn't even see it happening. I think honestly the fluoroscopic rate doesn't even allow you to capture that properly because it just happened so fast. But I immediately knew, right? I saw that loop on lateral particularly, and I understood that the catheter had enfolded on itself. It was really hard to understand why or what was the mechanism, and we can potentially go back to those images and you'll see that you cannot even tell, where it really goes, where it makes the curve. So I think I estimated where it is, but I still, until today, do not fully understand what was the exact shape that it ended up acquiring. So yes, as soon as I saw that, I knew that it was going to be, a big tear. I honestly expected more extravasation. I thought it was going to be, a massive rent, which maybe was that the case, but angiographically, there was still a lot of blood going through those branches. So I was impressed that it was not worse than it appeared angiographically. But again, the runs were very gentle. I was doing microcatheter puffs. So it's possible that if a legit run had been done, we would have seen a lot more.
But did you pull the microcatheter back? Because what I maybe I just missed this, but if you felt that you could have perforated or having extravasation, did you try to come back with the microcatheter, or did you try to maybe do a little microcatheter injection to see for sure if you were in the superaccurate space? And the reason why I'm asking this is because, as you know very well, is if maybe the microcatheter you knew already that was in the superaccurate space, perhaps retracting it back might not be a good option because you're going to have further extravasation. And I don't know exactly if you suspected that at that time or it was right after the run.
No, it's a good point. So, we use these terms and we don't talk much about them. In a way, it's a perforation, but, perforation I tend to reserve for, a wire perforation or a microcatheter perforation, which you have a little hole that you need to deal with. So I knew that it was much bigger than that. I knew that it was a big rent. So the vessel had been teared. There was no other option. So I could have maybe, puffed to understand. Someone could argue that maybe I was actually past the rent segment with the tip of the catheter and I could just have called from the back proximally, right? So that could have been a thought. But I knew that it was a massive rent and then I would just have to go there and kind of kill that rent, which is what I did. But yeah, maybe I could have puffed. But honestly, I think I tried to reduce a little bit to understand what was happening because I was not fully aware of what was happening. And and then you can see that that loop undoes or gets undone as I'm pulling back. And when I puff, I think I couldn't see any, I just can't remember details because I didn't document. But when I pulled it down is when I saw the rent. But again, I knew that I was going to have to deal with it. I don't think there was any, benefit of leaving the catheter there because the rent was so large that I knew that I would just fall in with a J-shaped microwire tip and I could be able to just coil. So my fear was honestly like, I need to do something quick, very quick, before the pressures go up in the brain and then I lose the patient. Indeed, when I did that microcatheter puff, the first thought, as you could see, the contrast was going up so slowly, I thought that there was already intracranial hypertension to the point that the patient didn't have perfusion anymore. But then I thought it was like, that's probably unlikely because there's contralateral cross flow and there is the ECA to ICA flow. So there's probably some resistance for this, mini puffing to be, leading to contrast going up. So yeah, it's a good point, but even retrospectively looking or thinking, I don't think it would have made a difference.
Ashu, Max, Mario, any comments? Any kind of
yes, the case is impressive, Joel. Thank you for showing. Maybe one idea is just to when you have the catheter first fall, just deploy a long coil, and then once it's partially open, then you may retrieve the microcatheter. At least you are, occluding the hole at least, and maybe some protective, for doing this maneuver. As Santi mentioned, I think it's not a good idea to retrieve the microcatheter, just leaving the perforation open. I don't know, because for example, we normally do it when we have a perforation during a stroke. Instead of occluding the artery, we deploy, and we know that for Chapeau, they place the coil, just leave it for 5-6 minutes, and then remove the coil. And you may achieve, a nice occlusion with a temporary occlusion with the coil.
Yeah, once again, good point, right? I have tried to do this before, to coil outside and then start coiling. So leave a bulk of coils in the subarachnoid space right around the artery, and then just pull it inside. You may run the risk of not being able to push the catheter out. Honestly, my experience that it doesn't work that well. So coiling the inside and then waiting for, it to thrombose and then removing the coil is another option. You probably have a lot of thrombosis forming around the coils and you're gonna have a little shower, also acceptable in the case of a perforation. I think honestly, to your point and to Santi's point, if I had the microcatheter past the clot and past the rand segment, I could have put a coil and then block the end of it, right? So I then coil this part and I'm not gonna have backfilling through collaterals, making it bleed through maybe an improperly coiled distal end of the stair. So yeah, that's certainly, makes complete sense. But yes, it would require amazing collaterals, which maybe she actually didn't have bad collateral. So it is a good point. Yeah.
Anything, Ashu or Max, to comment or any suggestions?
I was kind of curious about I think I recall this Orion catheter. I know it wasn't around for very long, but I remember using it a few times. Do you recall the visibility of that? Because I've had this doubling up issue, more often actually with the Velocity microcatheter, which I don't like to use because the tip is hard to see relative to other microcatheters. And so sometimes if we end up using a Velocity, I notice that like the tip, is kind of somewhere and you don't even realize that it's ahead of your wire because it's so hard to visualize. So I think part of this case, perhaps the challenge of this is just that it's hard to kind of visualize where that microcatheter tip is. And some of the other microcatheters seem to be a little bit easier to see, like the Headway 27 or even the Phenom 27. So I was wondering I know there's a lot of things that sort of likely contributed to this, but do you think that was a contributing factor?
Good point again. I think you may have seen the images of the fluoroscopic view. I think honestly standard. There was the proximal marker for coiling. So you had that idea of where the proximal end is. I think I had sufficient visibility, so I would never blame that. I honestly think that there's a few things that I could bring up that maybe we can discuss. So one is what I mentioned that, forcing something in the angel suite is not something that you should be doing, right? Like I regret every time that I force. It doesn't matter if it's your onyx syringe or if it's your microwire, it needs to be seamless and smooth. So I think that was probably the first mistake. The other thing that I mentioned is the 160 microcatheter. I am once again glad that they exist. For these patients in which you need to park the catheter low because you can't cross. You don't miss it. So you don't need to be stretching out to get across the clot. The other point is the balloon guide catheter being inflated, and it was very low. But inflating the balloon guide catheter gives you so much more power, and you need to be cognizant of that. I think that's probably what happened, is just I transitioned from not having much support and not having too much length, and I was just trying to make that effort to make the catheter move forward. And once I inflated the balloon, I just had, a massive anchor allowing me to push and do whatever I wanted. Is still interesting because I remember having a lot of wire passed. And again, you have the distal end of the synchro, super soft, but as you put that out, you have the stiffer part of the wire as the body and as the rail for you to just track your catheter over. So with all that, somehow I think as I was advancing, I may have pulled the wire, so I have the softer part of the wire inside of the catheter, and then it kind of folded on itself.
Well, we're gonna, I think, Max, unless you have any comments, I think we can maybe move to the next session, which is your session. And I have the opportunity and pleasure to really introduce you. Max Smokin doesn't need introduction, but I'm gonna just do it because, I have the pleasure to do so today. And he's an associate professor at the University of South Florida. He's really an expert in ischemic and hemorrhagic disease and flow diversion. And today he's going to share also a very interesting case with us about one of his patients that recently kind of dealt with and had a little bit of a nightmare. Go ahead, Max.
Thank you for the opportunity to present this case of a middle cerebral artery perforation during aspiration thrombectomy. My name is Maxim Mokin. I'm a neurointerventionalist at the University of South Florida, Tampa, Florida, United States. The case I'm presenting is an elderly patient, age over 85 years old, who presented with a classic left hemispheric syndrome, acute ischemic stroke. She did not receive intravenous thrombolysis. She was outside the window for that. And imaging was consistent with the proximal MCA distal M1 occlusion. After discussing with the family, we decided to proceed with thrombectomy. General anesthesia was used for this case, and as you can appreciate, the patient had quite tortuous access, including the left cervical carotid and its downstream regions. I will come back to the significance of this anatomy a little bit later. Our first approach to tackling this M1 bifurcation lesion was using an aspiration catheter, 6 French Sophia, and with a single pass, we achieved recanalization. But as you can appreciate on this lateral view with a dashed area, there was a distal perfusion defect consistent with a distal M3 occlusion. The red arrows point to the location of this lesion. We had a little bit of a difficulty visualizing it, but you can see on contrast stagnation where the distal embolus is present. So we decided to go for this more distal lesion with a smaller aspiration catheter. A 3 max was chosen. First, I attempted to reach the lesion just over micro guide wire alone. Subsequently, I used the microcatheter velocity to help me get to the occluded segment. And I have to point out there was tremendous difficulty selecting the vessel and also traversing the MCA bifurcation with 3 max. There was a lot of resistance encountered with me advancing the 3 max. And perhaps not surprisingly, the follow-up angiogram, I felt that there was way too much resistance outside of my comfort zone, and you appreciate a significant perforation noted intraprocedurally. My immediate bailout technique was to use a balloon. Most of the time, if a perforation is encountered during thrombectomy, inflation of the balloon temporarily, just for a couple of minutes, fixes the problem. Quite honest, often it's not even necessary because the clot tamponades the perforation, but here it's suspected the perforation occurred more proximally to where that M3 occlusion was seen, which is consistent with this angiographic appearance. Well, inflating and deflating the balloon several times, unfortunately, did not help. There was consistent extravasation noted angiographically. My next step was then try to temporarily use a coil to block the MCA more proximally. As you can see at the top of the screen, this is what I'm trying to do. Deploying the coil without detaching it in the past has helped me to temporarily tamponade the vessel, and then withdrawing the coil, you can continue the intervention if needed. Unfortunately, here, this temporarily occlusion with the coil mass was also unsuccessful, which I guess in hindsight is a little bit naive to think because I already tried this approach with a balloon and it failed. As you can see at the bottom of the screen, I then continued to coil the perforated segment, and still there were persistent contrast extravasation noted. And I think this signifies that I had difficulty localizing where the exact perforation took place. Eventually, I was able to achieve complete hemostasis, but that was at the price of essentially causing an ICA terminus occlusion in this case. As you may expect, the follow-up CAT scan looked quite scary with significant amount of contrast extravasation noted, more so on the left side than on the right side. Because the patient originally presented with significant devastating deficits from the initial stroke, the age was quite advanced, the family eventually elected to proceed comfort measures. There is two teaching points that I would like to make from this case. Number one, perhaps the most important one, was for me to realize that proximal access here was not adequate. Because of the significant tortuosity, and you see examples of a 360-degree loop of the distal cervical carotid, as well as multiple tortuosities of the carotid siphon, a more solid access is key. Back then, we had a rather limited number of proximal guides available. Currently, my approach to more significant tortuosity is using more guides that are more flexible, allowing an 088 guide to go all the way into the petrous, sometimes the cavernous segment. So here I'm presenting an example of what my current approach would be in a case of stroke thrombectomy, where I encounter significant either arch tortuosity or tortuosity of the carotid, or both, as shown in this case. And I think having a solid guide that you can advance as high as possible makes a big difference in being able to achieve precise control and feedback from downstream devices that are used for thrombectomy. Finally, I think that the second point that I'd like to make from this case is that perhaps we need to be less aggressive or have a low threshold to stop in cases of distal occlusions when we feel that significant resistance is encountered, as I have experienced in this case. Unfortunately, to this day, we sort of have just a rough estimation of what neurologic deficits would be in a patient with distal occlusions. In my case that I showed, initially we started with an M1 occlusion. After that, this would be a TK2B result, and perhaps I should have stopped instead of trying to push, going for this more distal occlusion. And this was just an example of a recent paper that we're focusing now, trying to understand the significance of eloquence in selecting different zones of this distal emboli and their clinical outcomes of being untreated. Thank you for allowing me. I'll finish, and hopefully it will generate some interesting questions. Thank you.
Thank you, Max. Also, really interesting case, and I'm sure everyone has some potential questions and comments. I'm going to start with